Please sit at the dinner table and eat with your family. Please go out and take the dog for a walk, right? Like those things. And then the gradual return to activity of early implementation of getting out and moving, which we know is associated with decreased protracted recovery.
Good morning. Welcome to In the ED Now, a podcast that makes you a better physical therapist in the emergency department and helps you practice at the top of your scope. I'm so excited today to have Dr. Becky Lewis with me, and I'm your host, Dr. Rebecca Griffith, the ED DPT. Welcome to the show.
Thanks so much for having me. This is exciting.
Well, I'm so excited you're here, but I think you need to tell people who you are so that they are excited that you're here once they know all the amazing knowledge that you have.
Okay, so I am a physical therapist. This is my 24th year in clinical practice, still clinically practicing, but have different roles. So I've kind of decreased the time in clinical practice as I've assumed these other roles. So my full-time job is I basically am faculty at the University of Kansas Medical Center in their newly developing, we just launched this summer, hybrid pathway to mirror the residential pathway. And the main goal of that is to actually keep individuals in their local communities to then elevate practice in those rural environments. So if you know anything about the Midwest, there are lots of rural communities. So I am in Columbia, Missouri, and even in my clinical practice, I serve a 90-mile radius of people that get referred for concussion to our clinic. But then if you think about rural Kansas, Nebraska, Colorado, Arkansas, Oklahoma, there really is some big gaps that, typically individuals, if they go to a residential program for physical therapy school, go to big cities, right, in suburban or urban areas, and then they fall in love and they don't go back home in their rural communities.
Right.
So right now we actually have several that are from rural areas across the Midwest. So it's super fun to interact with them. They've just launched their PT school journey, but really talking to them about how to translate this knowledge into their local communities. And we are working really strong with trying to set up their integrated clinical experiences in their practice settings there. So forming clinical relationships and all the things. So I'm excited to see where this goes in the next several years as we start admitting more and more students in our cohorts. So that's my full-time job. Then I also am program coordinator for the University of Missouri's neuro-physical therapy residency. So this will be our 5th cohort this year. We have our selected residents, so we'll be starting in a couple weeks. So I coordinate all the didactic, but I still clinically mentor. So I get to go to our mentor sessions and coach the residents in their decision-making, how things are going, feedback, all the things. So those are my 2 primary jobs. And then I do a lot of advocacy work as well as volunteer work for the Academy of Neurological Physical Therapy, as well as nationally on the APTA Concussion CPG Revision Group or Committee. So we are deep. I know people have been waiting for an update to the Concussion CPG that was published in 2020. So we are deep in interventional studies. So we're excited that we can maybe elevate and make more recommendations on interventional practices related to concussion, because that was one of the lacking areas in the first CPG. And there's a lot more studies now. So I work on that group. So I'm data extracting and looking at studies and all sorts of things. So I think that's probably a good summary of what my life entails on a daily basis.
Well, let's finish up. So, and tell everybody about your continuing education for concussion management, because people are looking for that.
Yeah. So that was another gap in when I would go across and deliver like 2-day seminars or 2-day courses. A gap was access to quality continuing ed that is up to date and immediately applicable. What we found is, so I've been providing continuing ed for the last 10 years. And so after COVID, I think we all know budgets were affected for CEU. And so also therapists have changed in their needs for education. Like I will tell you, like going to something and sitting 8 hours, or even if there's labs, going to a course in person is pretty rough on the way that we've adjusted. So our goal was to develop an on-demand, so learning at that individual's way, but still engaging and interactive. So I have partnered with 2 other individuals, because the other big need or gap out there that I keep hearing about is the bridge between ortho, neuro, and sports. So like if you get referred for concussion and it's a vestibular ocular, you're over here in like the neuro world. But those neurotherapists aren't always comfortable returning to sport, and vice versa, right? I feel great about sport, exertion, or the neck. I don't feel great about this vestibular ocular piece of it. And so this allows, well, what it creates is these individuals sometimes may have to go to 2 different PT appointments, right? Like I'm going to go get my neck work done and do exertion, and then I'm going to go do vestibular therapy or ocular therapy. And it's just a lot of extra time constraints for the individual as well as money. It's interesting. They actually address that in the article that we're going to discuss here in a minute too, as barriers. But so we really need to think about how do we all work together? We all have this knowledge, right? Like everyone has brains, everyone has musculoskeletal systems, and we often too many times silo these, right, apart from each other versus we're all equipped with the knowledge. We just might need some, extra coaching or education on how to integrate it. So that's the goal. So we launched the first part of a 3-part series for the continuing ed. And we've got people engaged from domestic to international. So it's exciting to see the reach because of the accessibility. The other big thing is affordability and keeping it at a really affordable price point to elevate knowledge across care. So we're excited for that.
Awesome. So this podcast obviously is for anybody who wants to practice at the top of their scope, but also people who practice specifically in the emergency department or urgent care type settings. And one of the big reasons people go to the emergency department is for head injury, right? And the head injuries are also really comorbid with trauma of all kinds. But I think one comment that stuck with me when I was learning about concussion originally is that concussion is a functional diagnosis and not an imaging diagnosis. Can you speak more to that? Because I think if we are going to be the people who are recommending imaging, who are helping managing some of these issues, like we need to truly understand, like, what is a concussion?
Yeah, absolutely. And I think that's what frustrates a lot of people is because we're still in the era of relying on patient symptoms. And now we have new objective measures, which validated measures in acute concussion assessment, like the SCAT-6, which is, but it's also the SCAT-6 is validated only in sport-related concussions. So then what do you do with the non-sport? Or those individuals like the middle-aged car accident or the older adult with a slip and fall that, we have to evaluate. So right now, concussion and mild TBI, AKA, are synonymous. I think sometimes that's confusing. But the other thing is right now, it is a functional injury. There is not a standard imaging measure. 99.5% of the time, the imaging is negative. There actually was several years ago, there was this big, as information about concussion was coming down the pipeline and people were more aware, this kind of happened with the evolution of Operation Iraqi and Enduring Freedom. And that's where I first started in my concussion career, was with the military and the tactical athlete. But as that awareness raised, people were like, oh, we should be imaging more, right? Like, how do we? So then in the pediatric urgent cares and, emergency rooms, they were imaging all of these kids every time. Well, we know CTs are exposure to radiation. They also saw an associated increase in childhood cancers along those times. So then there was this big like, wait, we don't need to image everybody, only in certain circumstances when there's progressive neurological like decompositions, right? So like recurrent vomiting, neurological signs and symptoms beyond, right, that are associated with a concussion. Slurred speech, paresis, passing out, loss of consciousness, in and out repetitively, not just on the injury. So all like those types of things. So we really had to do some knowledge translation of like, when is it appropriate to image versus not? And I can tell you when I see, pediatric to geriatric patients in the clinic right now, that's like, I can see from a 9-year-old all the way up to 100. And one of the biggest things are like, why haven't they done imaging of my head? Don't I need an MRI? And I'm like, actually, no, like MRI is non-radio, like ionizing, right? So that would be okay. But why didn't they do a CT of my brain? And I have to answer that question. Now, in older adults with mechanism of injury, when they slip and fall, there is the head CT, right? Like a logarithm that it is, because they could be slow bleeds from the integrity of the vasculature not being the same as we age. So, but being up to date of even that criteria to be able to explain that in layman terms to your patient, so that one, they are educated, two, they are reassured, and three, that this is a recoverable injury. So there's all sorts of things we can unpack with that, but it is right now functional. There are some, I just got back from the Concussion and Sport Groups meeting in Milwaukee several weeks ago, where they were talking about biomarkers and imaging. And so we still haven't narrowed it down. There's emerging biomarkers. We're looking at blood, we're looking at saliva, we're looking at all sorts of things. But the problem is so many of the inflammatory markers that they're looking at are associated with other conditions as well. And so if anybody heard there was a big announcement with the FDA several years ago, like, yay, we have a head injury, like FDA approved blood biomarker. Well, it actually isn't concussion, it was for a bleed. So basically they tied it to specific biomarkers. If somebody was actively bleeding in their brain, that they would be able to detect that by a blood biomarker or like an AccuCheck, like finger stick. But then you think about implementation and cost, and when is that going to become routine practice? Right? Like we have so many barriers and limitations for that. Imaging, functional MRI, if that was routine practice, that would be wonderful because we could see the connections and where things aren't making connections following head trauma, but that's not routine practice at all. And really right now it's only in research that individuals
are not going to do that in the emergency department. Nope. Like absolutely not. Right? You're not getting an MRI in the ED for a head injury unless it's like severe.
Right. Or they have like moderate to severe TBI symptomology. Right. Yeah, right. Exactly.
It has to be pretty impacted for us to get into the MRI machine. So one of the things that you wanted to talk about, which I was excited to learn about, is this pilot study about direct access PT in the pediatric emergency department. Now, there are not a ton of PTs that practice exclusively in pediatric ERs, but I think this information is like really good model to help us boost our practice in any emergency department. So can you share more about that?
Sure, absolutely. Yeah, it is. The lead author, Isabel, is actually on our concussion clinical practice guideline revision. So phenomenal to hear. Our colleagues in Canada, I will say, are doing wonderful things in the space of concussion. So between Isabel and then we also have Catherine Schneider, who was the first physical therapist on the Concussion and Sport Consensus Group white paper. So we knew as physical therapists for years that there was a role of PT following concussion, but we didn't have the evidence. And Catherine's initial RCT that she published, that the combination of cervical and vestibular rehab was superior in concussion, got us on the mark. So we are so blessed on our committee to have both Isabel and Catherine, who are publishing and doing the groundwork to lay for advancing physical therapy within this diagnosis. I got excited because this was published. I'd actually had some random emails from people that were like, does anybody know of any way that PTs are actually implemented in the ED to help this management of this? So like I was on emails and then all of a sudden like this publication, and I was like, well, let's get you connected to Isabel. And they actually were able to connect, which was fantastic. But the questions are asked, and then she did this feasibility study. It was in a pediatric ED. Physical therapists were not there at all times. They had active hours. So interesting enough, it was only 12 hours a week, but they looked at, I know. So the PTs were in for the active time, which was 12 hours a week. And basically it was from hours 1 p.m. and after, right? So 3 hours, 4 days a week, I think is what they pulled it. But they looked at the data. So they used the plan, do, act cycle, which is an implementation, right? Quality improvement assessment way to design things. And they looked at times in which the most referrals for pediatric head trauma happened.
Yes. And just as an aside, if you're trying to start your practice in the emergency department, arrival curves, you have to know what the arrival curves are for your primary complaints. Perfect example.
Yay. Okay. So, but to me, I live in the implementation science. I've had advanced training in the knowledge translation action cycle. So when I read this, I was like, yes, they did a preliminary needs assessment of when would this be most like beneficial, right? They actually used the data to design this feasibility study. And their goal was, is it feasible? Like, what are the benefits of this? And that's where they came in to see what were they actually going to measure, right? Like patient satisfaction, retainment of parents understanding the education, right? Because we can all do that. I think, how much do we talk and educate all day long, but how do we know that the recipient is actually understanding and retaining that info?
Especially in one of the potentially scariest moments of their life.
And especially when you add in the addition of they're a parent of their kiddo, where they may be seeing things that are abnormal in their behaviors, or they have an idea of, oh gosh, my kid had a head injury, and all of the sensationalism from media, right?
Yes.
Or information that's readily available that might be a little bit misconstrued. So you're absolutely right in the fact that they really looked at how can PT add value and also improve satisfaction, documentation, and care of the referrals of the individuals that have these like predisposing factors to have protracted recovery that they actually get to follow up. And that was their study, and it was pilot. And I looked at the numbers when they, like, all the people included, and the number of kiddos that they see in their ED for concussion was astounding to me. Close to 1,000, and that was in a 6-month period. And then I just kept thinking, well, gosh, this is kiddos. What about adults? Like, I don't know in my own ED here at MU Healthcare how many are coded as, you know what I mean, concussion or some type of an associated.
Yeah, and I think that's part of the problem, right? When you come into the emergency department, you're often diagnosed with the symptoms you came in with, not a diagnosis. So if you come in with nausea and vomiting, your diagnosis usually is nausea and vomiting. So in patients like this, their diagnosis might be fall. It might be motor vehicle accident. It might be head strike. I see head strike a lot, but patients are not often diagnosed with concussion or mild TBI. Like, that's just not a thing people usually leave the department with. And so that's another question that I have for you when we get to that point is, how do we not miss a concussion? Because every head injury is not a concussion.
Yeah.
So how are we delineating those that are? How do we get ourselves to the right patients, and how do we set those patients up for success immediately?
Yeah, absolutely. And that's where you have to look at, that's the other thing they looked at was time to see their first provider.
Right.
So time to first provider. And that's, they actually looked at when a PT plus an MD versus just the MD, it was actually leaning towards faster times when the PT was involved because they could be available to go in first. And
right,
that,
at the right time.
yeah. And oh, by the way, we're equipped with skills to administer. At that top point in time of the study, they did the SCAT-5 or the child SCAT-5. We've now had a new updated version of the SCAT-6, which is even more discriminatory and has additional measures that I think, like, gosh, if we did the SCAT-6 now, would be phenomenal. But really, we could save time on the physician side so that they could do more, right? Like visits and encounters. We're administering this outcome measure. We're also doing, the other thing they did was an additional like neurological screens that were, recommended just to have a full picture. Their information was then available to the physician to then look at before they went in to do their own physical exam as well if needed. If they felt like they needed, if not, they were like, well, it's already done. Now I can come in and do a little bit more explanation to the patient of what's going on and review, right? Yes, I think this is a concussion and these are my recommendations. And then after that, the PT goes back in to do the discharge summary with targeted education, but recommendations. So, and those are up-to-date recommendations, right? Like 24 to 48 hours of relative rest, not strict rest. Please sit at the dinner table and eat with your family. Please go out and take the dog for a walk, right? Like those things. And then the gradual return to activity of early implementation of getting out and moving, which we know is associated with decreased protracted recovery.
Yes, I recently had a family member who went to the emergency department with a head injury, and they told her strict 2 weeks bed rest, bathroom only.
And then we wonder why these patients become more complex because of the fear avoidance, the information they're told. They now consider this like a serious injury, right? And head injury is serious, but a mild TBI and concussion is not as serious, right, as others. But it's the stigma around it that is creating this fear avoidance, which is then, I don't know if you know this, but it was staggering to me to look at like overall money spent on injury. We spend more money on mild TBI and concussion than we do on moderate and severe.
It's the low back pain of the brain.
That is, I've never heard that, but you're absolutely right.
Because that's the other thing. Like, if you have a craniotomy, you're out of bed the same day, if not the next day. Like, you're walking the halls, you're in the chair, you're like talking to people, you're doing assessments, people are checking, you know, and then we're telling people with like a mild head injury to go home and lie in bed in the dark for 2 weeks. Like, we're harming people.
Our healthcare system is 100% harming people because of misinformation.
Yes.
And slow, like it's kind of funny. I'm actually doing qualitative data analysis right now. We did a follow-up survey to practicing physical therapists across the country about once they've read the CPG and used some of the implementation tools that we published with AMPT, what are their continued barriers to implementation? And there is a massive thread about our patients who, it's not us anymore. We're up to date as far as physical therapists. It's our referring providers who have not stayed up to date, not any fault of their own, right? Think about what we all have to do on our plate. And if they're not being targeted on updated practice patterns, guidelines, rest versus activity versus referral to PT in that ID window after injury, it's not their fault. It's their product of our organizational cultures and our healthcare system as well. But the biggest barrier to physical therapists implementing these practice guidelines is the referring provider's information provided to the patient. That is misinformation.
Yes.
And then delay in referral. And then now all these maladaptive things are happening because people are a little fearful or they don't like their symptoms and they didn't get addressed right away from a movement standpoint. That now we have this chronic complex patient that takes longer to recover because we have to unravel the maladaptive, the misinformation, and we have to do a lot of extra education and reassurance versus like in the study, if they do it from day of injury, the outcomes are better.
So let's take a pause to imagine some top of scope upstream practice where you have a physical therapist in every emergency department and urgent care that's seeing these patients immediately. That's step one. Or you have PTs on every sideline who are doing this. Or you have PTs that are going out to falls calls at homes with EMS and screening those patients with those falls at home before they're transported to the emergency department. You have home health therapists helping manage this. You have school-based therapists helping educate patients and families on this. Like, there are so many spaces where PTs could be the providers of choice here, where we're not waiting for those downstream referrals. We're not waiting for the adverse effects of that, but we're actually integrated into points in society where these head injuries happen so that we're not rehabilitating as many concussions.
Correct. Because they're getting the appropriate information at the right time to then allow them to take part in their own recovery and be active and feel empowered that they're not going to cause further injury because, right? Like, that's the biggest thing is the fear.
Yes.
And the lack of health literacy that the general population has about what is standard of care and top of scope practice for this injury. And we all know it takes 17 years from publication to transfer down, and it is rampant across the country, the misinformation that occurs. I mean, I actually just got contacted from an individual from England who on Instagram found me and was like, Becky, can you help me? I have been suffering for 2 months. He's an elite athlete over there, and he hasn't been referred because of the socialized medicine and some others. So he reached out to me on Instagram, and I was able to help him through within 4 days, no symptoms, and starting the return to sport protocol. And he had been experiencing symptoms for 2 months, right? And so this is just the added, this happens all the time. And how do we, like you said, right about sidelines, I have an amazing relationship with the athletic trainers locally in my city. So they actually are not employed by the hospital. They're employed by a private practice that have had the contract for years. And when I first got here, it was very like, oh, you can't be talking to them. They don't work for us, right? Like they're competition. And I was like, I'm sorry, I don't live by those rules. I am a disruptor. And these are the individuals caring for our athletes in the community. I am absolutely going to be inclusive. I'm absolutely going to reach out, but also show appreciation and gratitude for what they do on a daily basis.
Yeah.
And so through that, our ATs here have elevated practice. They are probably doing top of scope for them. And it's earlier, like I get texts all the time. Like, I just got one the other day from, Josh, and he was like, hey, Becky, I've got a kid. It's less than 5 days. Can I send him? Because I think this one's going to take. Absolutely.
Talk about a good referral source.
Oh my gosh, they're my best referral sources, but it's because of that respect for shared roles and responsibilities of everybody on the team for collaboration. And I think that can happen in the emergency department as well, right? If people understand the value that we can bring and add to these management of the conditions where it's appropriate.
So if I have a patient on my caseload and it says head injury, what do I do?
So yeah, how do you unpack that head injury to go in? One, do they fit any criteria that imaging would be warranted, right? So progressive neurological, has that been ruled out? Everything looks good. They're pretty stable. They report with signs and symptoms consistent with concussion. Then obviously, the SCAT-6 is a great place to start. There have been publications that the SCAT-6 is too long for emergency physicians to complete. So that's, again, where PT can come in and actually do administration of like incidence involvement, what happened, what were, their immediate symptoms. We know that immediate symptoms of headache, dizziness, and fogginess are associated with protracted recovery. So even getting that information and documenting it in the chart, which was part of this study of what the PTs did, when they compared documentation of prognostic factors of what was documented by PT versus MD, who do we think did a better job and that were actually in the patient's chart to then be followed more closely to get the right care, which was really great. So even getting all the information about kind of what happened at the scene, their continued symptoms, but going through, like for everyone that I see, even though it would be acute, and it is not on the SCAT-6 they've got cognitive, they've got memory, they've got some balance measures, they've got some complex walking measures to see how they do, because we know that those are all hallmark symptoms. But the other thing that I would do is, it's called the vestibular ocular motor screening tool, the VOMS, because that is actually shown to have beautiful numbers in psychometrics and sensitivity to help in diagnosis of concussion. The VOMS, the modified VOMS, is on the scope 6 currently for sport-related concussion, which is the 72-hour follow-up if they get to the provider, right, in 72 hours. I would jump one step ahead of that and do a VOMS in the emergency room. Okay. Because the sensitivity and the 2% false positive rate on assisting in identifying acute concussion. So then that, if you see deficits, well, patient education specific to that. You might experience symptoms, right? Like if it's a VOR issue, now you can educate them on what symptoms they might experience, right? In busy environments or while quickly turning their head. And what does that do? Because you're reassuring that that's normal based on their presentation. They aren't all right, like, oh my gosh, I got dizzy and now I'm going to tighten everything down and only move, right, like en blanc as the maladaptive strategy. So going through the VOMS, going through some balance measures, some cognitive screening, cervical assessment is key. We know that the link between, right, mild TBI, concussion, and then associated whiplash. So even getting them moving, see if they have any restrictions cervically early, is huge to start that process so that they're not decompensating or avoiding.
So we need to know our cervical spine imaging rules as well.
Yes, 100%. Absolutely. Some people have said, well, should we give them, it's called the Concussion Clinical Profile Screening Tool, CCPST, which is instead of the symptoms, like the post-concussive symptom scale, on a 0 to 6, how bad is your headache? How bad is your dizziness? Right. This one's more functional. but there's not any data that it's published. Like they don't have enough information if the injury just happened to know that, am I sleeping more than usual? I have no idea. I
Just got here.
So like this is where we actually have to use our clinical decision making and our like capacities in our brains instead of this cookie cutter, right, approach. Now different, here's a patient 1 week post head injury.
Yes.
Who's coming in for a continued headache. Beautiful time to implement the concussion CP screening tool because they've had a week. That will help identify the clinical trajectories of what the patient is still experiencing. Is it cervical, ocular, vestibular, exertional, cognitive? Is sleep an issue? Then that can help trigger referrals to specialty areas, right? And especially if it's at the 5-day mark, that's when rehab is key to be referred to, is any like that 5 to 10 day mark.
Okay. So what I'm hearing is receive a good history.
Yes.
Rule out the worst first.
Correct.
See what impairments you can manage today.
100%.
Make sure the patient's safe.
Yes.
Identify risk factors.
Especially for prognostic of those who are at risk of a longer recovery because of prior past medical history, correct?
Normalize expectations.
Yes, so that they're reassured.
Yes, and make appropriate referrals.
100%. All those. Can we just package that up and just have a flow chart for concussion for people? I mean,
you know, I think that's how you manage every patient in the emergency department, but that's just my flow chart for patient management in the emergency department. So the reason that I say that is so that if you're listening to this and you're like, oh my gosh, concussion, like I'm not a vestibular specialist. I'm not a sports specialist. I'm not a neuro specialist. I'm not an ortho specialist. That's okay. If you follow this pattern of worst, like receive a great history, worst first, manage what you can manage today, educate your patient and refer them to the next best step. That's all you have to be able to do. You don't have to be a Dr. Bliss who can get an athlete from across the ocean back to sport in 4 days. You need to make sure that this patient doesn't come back to the emergency department, doesn't hurt themselves, and gets the care they need. That's it.
And I really think, because if we look at reoccurrence of visits because of continued symptoms surrounding this injury, that would unclog urgent and EDs. So that, right, like, because this is a low acuity injury, this would open it up for access for those who have more higher acuity injuries as well too, because you don't have that subsequent. And we experienced that here at MU. I took my kid for strep throat to urgent care and I had my badge on because I was getting off of work. And the PA in urgent care was like, Bless, you're the gal doing that concussion stuff. And I was like, yes. And I'm kind of like, oh, is this going to go good or bad? Like, you never know, right? And she's like, can I just thank you? Because our knowledge translation project that we did at MU was basically we manipulated our EMR. And this is like, you know, we had to think about how do we get these referrals? So when we first started and looked at baseline data, the average time to referral to PT was 6 months for a concussion. So these people are living with these symptomologies, right, that are affecting all of life. And then here's where the increase in cost. They're now going to neurology for their headache. They're going to all these specialists versus not being managed. And so we took that, because of that, we were like, okay, trying to educate providers in a med school environment where the residents rotate so often is like you're chasing your tail, right? So instead, we had an amazing manager who manipulated the EMR. So we went into our big Epic system and made a trigger that if anyone had an ICD-10 code of concussion, it automatically triggered a rehab referral. So, and the doctor had to uncheck that box if they didn't want them going. And so what that happened, what that elicited was somebody following up. Doesn't mean they all came to our practice. We trained our front office patient care representatives to screen. They would make the call at day 5. How are you doing? Do you have any continued symptoms? And based on that, refer to the appropriate rehab provider. PT, OT, speech, neuropsych for anxiety, right? And so all of that was blanketed. They had it in their chart as an order. It didn't mean they had to use those orders. So when I go into urgent care, this PA is like, you don't understand. When we see somebody with concussion, we know there's follow-up, and our reoccurrence visits are 0 now. We're not seeing these patients for a headache every 5 days, or continued symptoms where they haven't gotten care. So she was so thankful of what just that one, and I say manipulation, right? But like that one little thing that we did in our EMR to just help with access to care.
Well, and I think that's a critical piece too, because if you're a PT practicing in the emergency department or trying to start your practice, one of the biggest metrics that emergency departments get measured on is recidivism and that bounce back rate. And the number of patients that bounce back for alarming symptoms, because what they tell you when you leave is if you don't get any better, come back. Or if it gets worse, come back. And it's green and it feels super scary. The other issue is obviously a lot of patients don't have the health literacy to know where to go. Additionally, they might not have the funding source to have places to go. So we need to be really clear with our education as well. But one of the reasons that I started really focusing on EDPT practice was I had a patient in the emergency department who had been in a car accident, unwitnessed car accident, was found unconscious, hit his head, went to the emergency department, had imaging. They gave him opioids and benzos. He went home. He progressively got worse and worse. He went to the ED again. He did that 3-4 times until he was like essentially non-functional, to the point where family was like locking him in a room because he was scaring them. He wasn't functional. He couldn't walk. He couldn't keep his head up. And he ended up being brought to our hospital with self-harming behavior because he was suffering so much. And every time he went to the ED, they just gave him more pain meds and more benzos. And obviously that's not a great combination for somebody with a head injury. So at that point, we were able to get him a comprehensive evaluation from PT, OT, and speech, as well as PM&R, and get that patient to charity acute rehab so that they could return to society as a functional business owner and family member. And that's one reason why I think we need to look at this population a little more closely. Other thing, a really important thing that you just said was about manipulating the order set. When you are working with patients in the emergency department, the best way to embed your practice is to have algorithms at which point PT gets involved. And so I would highly recommend anybody listening, think about what was just said and think what is your head injury algorithm at your hospital? And at what point does physical therapy need to be inserted into that? Because providers are following those algorithms. That's what they're expected to do. Those are their pathways. And so if you get into that pathway, the default will not be to skip you. The default will to be go to you at the appropriate time. So that's a great example of that as well.
Yeah. We were thankful just for outside the box thinking, right? Like a lot of people think oh, that'll never happen. Oh, I can never do that. Oh, I have so many barriers. Well, you know what? It's going to take us to think outside the box, be innovative, to then find these solutions to improve care moving forward, right? And you and I have had these conversations. So
scope culture shift.
For sure. Absolutely.
So if people want to learn more about concussion rehab, because they're like, that was great, but now I'm just realizing I've just skimmed the surface and I need a deeper dive so I feel comfortable with this, where should they find you?
They can find me. I'm all over socials. So, and just my personal, I link everything personal just from access. But then if you visit our website, www.blissfullyinbalance.com, you can sign up for a newsletter. Every week I publish a newsletter of what is the big thing coming down the pipeline, whether it be these conversations, like the role of the ATPT collaboration of best care for concussion, that was this last week's. Sometimes we unpack research articles and it's free as far as a newsletter, and then, explore resources of that. But if you follow me on socials, I do a ton of knowledge translation. So quickly summarizing the research that comes out weekly, right? We did it. I did a nice little one for this article of the take homes, because I know full-time practicing clinicians, it is so hard to keep up to date on evidence-based practice. So how do we make this easy and to keep the curiosity of, oh, I saw this and I want to dive deeper. And that's the big thing of kind of my mission and goal is to improve care across the world. I guess I used to say the United States. Now I'm saying the world. Yes. To decrease the amount of time that these patients suffer and to make them realize that this is something that they can recover from.
Amazing. So last question that I ask everybody is, what's your top of scope takeaway tip? Doesn't have to be concussion based, anything for a physical therapist to help them practice at the top of their scope.
The biggest thing, and this is probably more so because of my neuro background, top of scope is, I love my friend Rich Severin, like vitals are vital, even in concussion management, but it's across everything. We have such an opportunity to interact, educate, catch things, and especially with concussion, with the exertional intolerance and autonomic nervous system dysregulation, like please, 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 top of scope, and I'll scream it from the rooftops of using vital signs to help with your clinical decision making, and also to help educate our populations, right, for improved health overall, depending on what we do or do not discover. So
I think that's a great tip. And I had somebody recently say in their private practice, they just didn't have time to screen everybody's vitals. But I have found in talking to some other folks that if they put the equipment in their waiting room and they teach the patient how to take their own vitals on their first session, then their patient can come in and while they're waiting, take their vitals, record them, give them to the PT for that day. They can do it on their way out. That also teaches the patient how to take accountability for their own vital sign monitoring.
Yes, that is brilliant. Oh my goodness gracious. I might have to take that one.
It saves time, moves patients forward, makes sure we're monitoring their vitals, especially when you look at patients' medication lists. So that's what I'd add to that. Look at their vitals, know what's on their medication list.
Awesome. 100%. So.
Well, thank you so much for being on the podcast today. You have been in the ED now and you're officially discharged.
Thanks. Have a great one.
You too. Thank you for listening. In the ED Now is a podcast hosted and produced by Rebecca Griffith, the ED DPT, as part of Rebecca Griffith Physical Therapy, LLC. Our podcast makes you an excellent emergency department physical therapist. This podcast is intended for educational use only and is not intended as clinical or medical advice. While we make every effort for accuracy, factual errors may be present. Since you've been in the ED, I'm prepared to give you your discharge instructions. Please subscribe, share, and find more at theeddpt.com. You're officially discharged.